Hello, welcome to Valley View University. My name is Trevor Gerber. I'm a physician assistant in the Heart and Vascular Center here at Valley View Hospital, and just want to cover a couple of housekeeping items before we get started. First, you can submit your questions through the Q&A chat at the bottom of your screen. Your questions could be answered live at the end of the presentation, so if you do ask a question, we ask that you hang around, and I'll hopefully be able to we'll try our best to get to all of your questions. And if we're unable to answer your questions regarding, if we don't get to it, pardon me, if we're unable to answer questions regarding any personal health information that you put in there, so please keep these questions general. All right, let's get started here. Right. Right. Advance here, not advancing.
Click once.
All right. It's important for me to say that this content is only for informational purposes and should not be used in lieu of an actual doctor's visit. Today, we're going to review basic anatomy of the heart, and then we will move on to discuss the different types of aortic valve disorders, including risk factors, symptoms associated with aortic valve disorders, as well as how we diagnose aortic valve disorders and how we treat diseases of the aortic valve. All right, first, let's talk a little about anatomy. My cursor here will point out some of the structures of the heart. The heart is made up of four chambers. You have the right atrium here, right ventricle here, left atrium here, and left ventricle down here. This illustration is how the heart sits in the chest, and so the structures on the right, on the left of your screen, are on in the right side of your body. Between the right atrium and the right ventricle is the tricuspid valve. Blood flows in from the rest of your body, returns to the right atrium, crosses the tricuspid valve into the right ventricle, and then crosses the pulmonary valve and goes through the pulmonary artery where blood goes out to the lungs to be oxygenated. After the blood is oxygenated, the blood returns to the heart from the left atrium and then crosses the mitral valve into the left ventricle, which is the main pumping chamber of the heart. You can see the thick muscle surrounding the left ventricle. The blood then passes through the aortic valve into the aorta and out to the rest of your body. When one or more of these valves is diseased or damaged, it can affect blood flow between the heart and the rest of your body. Today, we're really going to focus on the aortic valve. Typically, aortic valve disease is a degenerative problem. As we live longer, we're more likely to develop an aortic valve disorder. About 5% of patients over the age of 75 develop moderate to severe aortic valve disease. There's two types of aortic valve disorders we're going to talk about: aortic stenosis and aortic regurgitation. Thinking back to our anatomy, the aortic valve itself is made up of three leaflets or cusps. These cusps are flaps of tissue that open and close with each heartbeat to allow the blood to cross from one chamber to the next. With aortic stenosis, these valve cusps do not open properly. Sometimes these valve cusps can become thick and stiff, or the cusps can become fused together. This causes the valve opening to become narrow, and this narrowed aortic valve reduces blood flow from the heart to the rest of the body. In aortic regurgitation, the valve cusps do not close properly. This causes the valve to leak, with blood flowing backward into the left ventricle instead of toward the rest of your body. This here is a depiction of aortic valve stenosis. So in red here, you can see the normal flow of blood from the right ventricle across the aortic valve and into the aorta. But with a narrowed aortic valve, as you can see on the right of the screen here, this very small opening in this tri-leaflet aortic valve, um, the blood can't pass through there very freely. And as the valve becomes narrower and narrower, the left ventricle has to pump harder, and what we call hypertrophy, where the muscle itself gets thicker in order to overcome this tight aortic valve. So what are some risk factors for developing aortic stenosis? Well, again, this is typically caused by a degeneration of the valve itself that occurs over decades. Risk factors for degenerative aortic valve disease are similar to what we see associated with arteriosclerosis or disease in our arteries. These include age. With each year, 10-year increase in age, the risk for developing an aortic valve stenosis doubles. Males have a twofold increase risk of aortic valve stenosis compared to females. Those who smoke have a 35% increased risk of developing this disease. High blood pressure causes a 20% increased risk of developing aortic stenosis, as well as high cholesterol. Some patients are born with an aortic valve that only has 2 leaflets instead of 3 leaflets. This is called a bicuspid aortic valve, and it affects 1 to 2% of the population. Those with a bicuspid aortic valve often develop aortic stenosis in their 5th or 6th decade of life. So what are some of the symptoms associated with aortic stenosis? Well, often patients, even with advancing aortic stenosis, remain without symptoms for a prolonged period of time. But as the degree of narrowing gets smaller and smaller, the ability for the blood to move across the aortic valve creates symptoms including shortness of breath, especially when one is exerting themselves. The patients can become dizzy or have fainting spells, what we call syncope. Chest pain is common with aortic stenosis because as blood passes from the left ventricle across the aortic valve into the aorta, the first 2 blood vessels that come off the aorta are the coronary arteries, and the coronary arteries feed the muscle in the heart. And so when one exerts themselves and has tight aortic stenosis, often the heart muscle can be starved of blood, causing what we call angina. Additionally, patients with aortic stenosis can become easily fatigued or have a decreased activity tolerance. And atrial fibrillation, which is an irregular heart rhythm, is common with severe aortic stenosis and may predispose or precipitate the onset of symptoms. Patients may first present with AFib, not recognizing they have a tight aortic valve. If aortic stenosis goes untreated, patients can often develop complications. And these complications include heart failure, which can include shortness of breath, leg swelling, water weight gain. Patients can also develop blood clots or bleeding tendencies, easy bruising. Without treating severe aortic stenosis, one can experience sudden cardiac death. Heart rhythm problems are also common with aortic stenosis, including atrial fibrillation, supraventricular tachycardia, and more lethal heart rhythm problems, including ventricular tachycardia and ventricular fibrillation. Additionally, about 15% of aortic stenosis patients have pulmonary hypertension, which is a backing up of blood into the lungs, causing increased blood pressure in the lungs. Let's turn our attention to aortic regurgitation. Again, you recall that aortic regurgitation is caused by a disease that prevents the aortic valve from closing properly. So blood, if you can see with this purple arrow here, blood, instead of crossing the aortic valve and going out to the rest of the body, it easily crosses backward across the aortic valve, filling the left ventricle and not getting blood to your brain and fingers and your toes. On the right side of your screen here, you can see this three-leaflet aortic valve that is supposed to be in a closed position, but has a weakened cusps that keep the valve open. Aortic regurgitation is less common than aortic stenosis. It can be acute or chronic. In acute aortic regurgitation, it's most commonly due to an aortic dissection, which is that main water line that leaves the heart. The aorta dissects or it tears, therefore causing a disruption of the valve that's upstream on the aorta. Acute aortic regurgitation can also be associated with endocarditis, which is an infection of the valve itself, that the infection sets up shop on one of the valve cusps, weighing it down and preventing the leaflets from closing properly. Chronic aortic regurgitation is most commonly due to dilation of the aorta. This is usually associated with untreated high blood pressure or sometimes a congenital aortic disease, but with time and high blood pressure, the aorta stretches, and this stretches out the mechanism of the aortic valve, causing it to leak. Patients with bad aortic stenosis, remembering a narrowing of the aortic valve, can also have a valve that doesn't close tightly as well. So they have aortic stenosis in association with aortic regurgitation. And then patients with bicuspid aortic valve, as I mentioned previously, it's not uncommon with only two leaflets that the valve doesn't come together tightly and therefore leaks. Symptoms associated with aortic regurgitation are similar to symptoms associated with aortic stenosis. We often see shortness of breath, especially when one is climbing a flight of stairs or, exerting themselves. Heart failure symptoms like fatigue, leg swelling, water weight gain, chest pain, especially when exerting themselves. Patients with aortic regurgitation can also develop nocturnal abdominal discomfort. This has to do with a lack of blood flow to the abdominal organs, and also uncomfortable awareness of your heartbeat, what we call palpitations, especially when one is lying down, is associated with aortic regurgitation. If aortic regurgitation is left untreated, it's common for the left ventricle to start to wear out, developing heart failure symptoms. Patients can also develop syncope or fainting spells. Patients with aortic regurgitation are also at increased risk for endocarditis, which is an infection of the valve itself, as well as heart rhythm problems and sudden cardiac death. So how do we diagnose aortic valve disorders? Oftentimes, a primary care provider or a cardiologist will put a stethoscope on a patient's chest and hear a murmur. A murmur is an abnormal audible sound of blood moving across a valve. Aortic stenosis and aortic regurgitation have distinct murmurs that a trained ear can pick up on. But an echocardiogram really is the gold standard test that we use to not only diagnose but also stage valve disorders, including aortic regurgitation and aortic stenosis. An echocardiogram is an ultrasound probe that is put over the surface of your chest and can pick up blood moving across the valves and discern if there's disease in any of those valves. Additionally, your doctor will likely order an EKG to assess heart rhythm issues, a chest x-ray to assess other potential causes of shortness of breath, as well as what we call pulmonary edema. Sometimes your doctor will order a CAT scan to assess the aorta, making sure that's healthy, as well as the calcium burden around your heart. If a patient has an aortic valve disorder, a cardiologist will need to perform a cardiac catheterization to assess coronary artery disease in planning for aortic valve intervention. With an echocardiogram, we can stage the severity of aortic valve disease. Stage A is a patient who has minimal aortic valve disease has no symptoms but is at an increased risk for developing an aortic valve disorder. Stage B is progressive mild to moderate aortic valve disease, but no symptoms are present. Stage C is severe aortic valve disease, but no symptoms are present. And stage D is severe aortic valve disease with patients who are symptomatic. It's important to stage aortic valve disorders because treatment depends on its severity. For mild to moderate asymptomatic disease, those that are in stages A or B, we recommend tight blood pressure control, refraining from smoking, and getting regular checkups with your cardiologist for serial echocardiograms. Remember, aortic valve disorders are a progressive problem, and that typically these aortic stenosis or aortic regurgitation typically progresses and gets worse with time. So having a repeat echocardiogram is important to follow the progression of the disease. For patients with severe disease, with or without symptoms, that's stage C or stage D, then aortic valve repair or replacement is indicated. Let's turn our attention to treatment of aortic valve disorders. An aortic valve can sometimes be repaired. This is not very common, but it can be done in some situations. It typically requires open heart surgery where a surgeon might add support to the base of the aortic valve. They might reshape or remove excess tissue to allow the cusp to close tightly. Sometimes a surgeon can patch a hole or tear in one of the cusps or separate cusps that have been fused together. There's also a less invasive procedure called a balloon valvotomy, which is done through an artery in the groin. This is reserved for patients that are very high risk for surgery or are considered inoperable, and it's usually a temporary measure. Most commonly, patients with aortic valve disorders require aortic valve replacement. This can be performed via two approaches. Surgical aortic valve replacement is done via open heart surgery, and a transcatheter aortic valve, also called TAVR, is done minimally invasively. SAVR, or surgical aortic valve replacement, is preferred in patients with a longer life expectancy, typically greater than 20 years. Additionally, patients that need bypass surgery or another valve that has some issues that need to be addressed typically are referred for surgical aortic valve replacement over TAVR, so those other problems can be addressed at the same time. Sometimes patients are referred for TAVR, but then in their workup for that procedure find that that the approach for TAVR is too difficult in that patient, and those patients are subsequently referred for surgical aortic valve replacement. TAVR, on the other hand, is typically for older patients with a life expectancy greater than 10 years. It is a good option for patients that are high risk for surgical aortic valve replacement. It is important to note that TAVR is rarely feasible in patients with aortic regurgitation. The aortic stenosis is a part, as we'll get to a depiction of TAVR, aortic stenosis is important to allow these TAVR valves to seat into the aorta. So without a lot of aortic calcium or valvular calcium, it's difficult for a TAVR valve to seat into place. So that's why it's only typically used for aortic stenosis and not aortic regurgitation. This here is a depiction of our heart team doing a surgical aortic valve replacement. You can see four hands there, two sets of hands, a surgeon and an assistant. You got an open heart, open chest there with a, in the middle here, a bioprosthetic valve. These strings here are the sutures we use. The old stenotic or regurgitant aortic valve is cut out, and new sutures and this valve are sewn into place. with surgical aortic valve replacement, we use typically two different types of heart valves. Mechanical valves, the one depicted on the right of the screen, are made of titanium or carbon. These valves typically last the life of the patient, so they're typically very long lasting, but they require lifelong blood thinners. And so patients that are at increased risk of bleeding or falling, those sorts of things are not typically a good candidate for a mechanical valve, as they will need lifelong blood thinners. On the left of your screen here are biologic or bioprosthetic valves. They are typically made up of cow or pig parts, bovine or porcine parts that are fashioned onto a stent that are shaped into the valve that will be implanted. These are less durable than mechanical valves. Typically, they last somewhere between 10 and 15 years. But the benefit of bioprosthetic valves are that they do not require lifelong anticoagulation. And biologic valves are the most common valves that are implanted via a SAVR. Here, a transcatheter aortic valve replacement depiction. In TAVR, this is a minimally invasive procedure where the groin artery is accessed, and a catheter, kind of represented by my arrow here, is placed into the arterial system and then retrograde put into the aorta across the aortic valve. On this catheter is a balloon with a new bioprosthetic stented valve around the balloon. And so the new valve is placed into the old valve. The old valve is not cut out, but once the balloon and the catheter are in position, the balloon is expanded, pushing the new bioprosthetic valve into place where it connects to the aortic valve and the aorta. And then the balloon is deflated and the catheter is removed, leaving the aortic valve prosthesis behind. Don't know what happened, but don't know what happened there, but I think we're back online here. We get back to where we were, just discussing TAVR procedure. All right, we're just about ramping up here. Once diagnosed with aortic valve disease, it's important to have regular checkups with your cardiologist or primary care physician. Things you can do to decrease your risk for progression of aortic valve disease include eating a heart-healthy diet, which is a diet rich in fruits and vegetables, low-fat dairy products, poultry, fish, and whole grains. It's important to avoid saturated fats, excess salt, and sugar, things we all love. It's wise to maintain a healthy weight and get regular exercise. Aim for at least 30 minutes of moderate physical activity each day. I do recommend you check with your doctor before starting any new exercise regimen. It's also important to manage your stress to decrease your risk for aortic valve disease progression. Things like exercise can help. Mindfulness, support groups, and therapy can all help with this. And lastly, if you smoke, refraining from smoking is strongly recommended. Again, going back to patients who smoke having a 35% increased risk of progression of aortic valve disorders. So if you smoke, best thing you can do for yourself is stop smoking. Well, thank you for participating in this Valley View University presentation. That's all I have for my presentation. But I do want to focus now on the question and answer part. So we will get to some of those. Hopefully we can get to all of your questions.
Okay, thank you for that
Excellent presentation, Trevor. I have a question here from the audience. I was told that I have a dilated aortic valve. What does that mean?
All right, I'm going to repeat the question. Somebody had asked, they were told they have a dilated aortic valve, and what does that mean? Typically, again, as the aorta dilates, the aortic valve is the first thing that comes off the aorta. So if your aorta dilates, oftentimes the mechanism, the annulus that the aortic valve sits in dilates as well, and that can prevent the aortic valve cusps from coming together, what we call aortic regurgitation. So for that person with a dilated aortic valve, it's important to control blood pressure. It's important to get serial echocardiograms to ensure that your level of regurgitation is such that you're not at a point where you need that replaced. So I encourage you, if you're told that you've got an aortic valve that's dilated, to keep your follow-ups and
Thank you. A couple more questions. The next question being, what is typically done once a replacement valve wears out? What are my options?
great question. Question is, what happens when my aortic valve that's been replaced wears out? Really depends on multiple factors, including how old the patient is. Also, what type of valve was placed originally. So again, with mechanical valves, which are made of metal, titanium or carbon, if a patient had one of those placed and that valve wore out, then typically you would need a repeat open heart surgery to remove that old valve and then put a new valve in place. However, if you have a biologic valve, oftentimes a patient can have a TAVR valve placed inside that bioprosthetic valve. So similar to your native aortic valve, the TAVR valve can be deployed and smush your bioprosthetic valve out of the way. And now you'll have a new valve. It's going to be a little smaller than your bioprosthetic valve typically, but oftentimes as one advances in age, the risk for surgery goes up as well. And so doctors have to get creative in how to treat aortic valve disorders. And we are fortunate to have multiple tools instead of open heart surgery alone. TAVR may be indicated. So great question.
Next question along the same lines of the bioprosthetic valve. What if a pig valve life expectancy, what is a pig valve life expectancy? Dad has had his about 11 years now. And what would his options be?
Yeah. The question is, a patient's father has a pig valve, so a bioprosthetic valve that has been placed 11 years ago. What is the life expectancy and what would happen if this thing wears out? So great question. Life expectancy can be up to 15 years with a bioprosthetic valve, sometimes even longer, but rarely. And when that valve wears out, it typically needs to be replaced. If your dad is young enough, he might be considered for a reoperation, open heart surgery, where they'd go in, cut the old valve out, and then put another valve in place. If he's deemed to be too high risk for another open heart surgery, then he would likely be referred for a TAVR, the transcatheter aortic valve replacement, where they would put the catheter through the groin with the valve and then deploy it in right inside the bioprosthetic valve that he has and pushing that out of the way. So,
thank you. Last question. Are you seeing new patients? And if so, how do we schedule?
Oh, great question. Yes, we are seeing new patients. And if you go back to the slide, you've got my website there as well as our phone number. We're at the Heart and Vascular Center here at Valley View Hospital. We are taking new patients and happy to see you or one of your loved ones, and we will offer great heart care.
Thank you so much, Trevor.
You're welcome. That's all the questions we have. Our team would love to hear your feedback on today's presentation. If you have time to fill out a quick survey, it will appear at the right after the webinar has ended. You will also receive an email with a recording of this webinar sometime in the next 24 hours or so. Thank you again for joining us today. I hope you have a great rest of your day.